Started. So welcome to this year's second CPC. I'm Francis Lowe, one of the chief residents here, and we've got an excellent case for you today. Our discussant is Dr. Andrej Spec. Got our disclosures up here beforehand. Case today is a case of a 79-year-old female with a history of ESRD, status was a renal transplant. It's a living-related CMV donor-negative recipient positive 11 months ago. And she's coming in with headaches, confusions, and skin lesions. And before we get started, we'll get to know our expert a little bit here. So Dr. Spec is an associate professor of medicine here in the Division of Infectious Disease. His undergraduate was Loyola University. He got his MSCI at WashU, his medical school at University of Illinois in Chicago, and residency at Rush University, and then fellowship here at WashU. So we'll take it back to the case. And so as a reminder for CPC, so Dr. Spec, this is the only information that he's gotten up until this point. So you all have the same information that he has, and he'll walk us through how he's approaching the data. And we are very lucky to have him today to learn from. Most welcome.
So, thank you. This is actually a lot more than I normally get. I think I did a CPC once where I was told like the patient came in with like leg cellulitis, but it turned out that there was just like swelling in the legs, and the real presentation was like preseptal cellulitis from Loa Loa. And I didn't know that he was actually from Africa. That was cruel. This seems a little more manageable. And so you pick your physician, you pick your disease. And so you tell me this, my first thought is an endemic mycosis or cryptococcus. But that doesn't mean necessarily that's where the differential should stop. So the first thought of, if you're trying to connect a headache in an immunocompromised patient, you're thinking meningitis. And then if you're thinking on top of that, a skin lesion, something like crypto meningitis with a skin lesion would be very reasonable diagnosis. Blastomycosis would also be on the differential with a brain abscess, as would cocci, assuming that he has appropriate exposures. Aspergillus, less likely, but certainly can happen. A renal transplant patient is not the highest risk for that. Then also tuberculosis and non-tuberculous mycobacteria. You say a skin lesion. I've already mentioned other mycobacteria. I'm putting leprosy on the list. This is not the leprosy, probably. If it is, kudos. Other infections to consider would be nocardia. Nocardia is also going to kind of have a brain-skin axis. Bartonella, Q fever, tularemia. And then if we're moving away more from these larger skin lesions, because when you say skin lesions, I tend to usually think more like nodules or a larger entity, but skin lesions could also mean rash. We could think of something like RMSF or Ehrlichia, Bourbon virus, Heartland virus, syphilis. And then there's a few different non-infectious things that it could be that I think are less likely. So sarcoid seems unlikely given the fact that she's immunosuppressed already, and that would be the treatment for her transplant would likely be treating her sarcoid as well. And then there is a possibility of something along the lines of like PTLD or another malignancy that related or unrelated to her transplant. And so that would be my initial thoughts, and then I'll turn over to you for the more information.
Sure. I guess one question I did have is, did any of the information, for example, the time course since the transplant, did that impact how you were thinking about your differential at all? Or the donor negative, recipient positive, as opposed to the reverse?
Yeah, sure. So she's not in the lowest category of risk for CMV. That would be donor negative, recipient negative, because then you are just worried about new acquisition of CMV, not reactivation. But she's in a pretty low risk category because she's donor negative, recipient positive. So I think CMV is a less likely thing in my differential, especially because we usually don't see it present with headaches and altered mental status and confusion. So that seems to be an unrelated. In terms of 11 months, that is a time frame where we often kind of march it out, but I always like to say that the infections don't read the same textbooks that we do. And so, yes, some of these infections have become more common later on, but we actually have a paper that's out that's just received feedback that we're going to be submitting soon that in a lot of transplant patients, about 25% of histoplasmosis happens in the first year. So it's more common later, but it certainly happens. And so I think for your initial broad differential, it still remains. It may become less likely later on, but it remains.
Okay. All right. So per your request, we've got some further information here. So 5 months ago is when this kind of all started, post-transplant 11 months ago, with a labial lesion that was positive with an HSV2 swab, and it got better with some treatment. Then 6 weeks ago, she started noting on her right arm, painful, about dime-sized draining lesion, and started to have a couple other lesions that popped up on her chest, her upper lip, her right knee. She was treated with doxycycline. And then about a month ago, so 4 weeks, she started to have a frontal headache that was described as a vice-like, non-positional, no neck pain or stiffness. They treated her. She went to the emergency department, and she was treated as having sinusitis with amoxicillin. Didn't get any better. And then for her headache, they treated her with tramadol and Fioricet, and she didn't get any better. Then the reason why she presented to the Outset Hospital is because then she started noticing, family noticed that she was getting increasingly confused. The chart is a little bit unclear about whether it's like hallucinations versus just lethargy. And then also she was reporting some changes in her vision with some irritation of the eyes and some spots.
So that's really interesting. So there's actually a couple of things that are worth discussing. So do you know what her prophylaxis for CMV was?
You'll get that.
You'll get it later. Okay. So if her prophylaxis was recently discontinued, or discontinued about 6 months, which is when about 5 months ago would have 6 months time course, that could suggest that she has lost control of her ability to control herpes viruses. And an infection, CNS infection could be possible with, more likely with HSV and VZV than it would be with CMV. But ganciclovir would have covered those and prophylaxed against that. What's really interesting is that the vision changes. So I wonder if she would have had HSV in her eye. CMV is something that we talk about a lot, the CMV retinitis, but CMV is a funny disease. If you pick your underlying disease, you pick your disease. And so CMV retinitis in transplant is actually quite rare. I know it's been described. I don't think I've ever seen a case of it. Whereas in HIV positive patients who live with HIV, we see it all the time. And so CMV behaves very differently depending on the underlying status. And so if you have HIV, it tends to be a very neurotropic disease. You tend to see retinitis, you see ventricular encephalitis, and you see a polyneuronal disease as well. Whereas with transplant, you tend to see end organ disease, so lungs, liver, kidneys. And so it's possible, but I think it's unlikely to connect CMV. But HSV certainly becomes part of the differential as we learn, especially if we learn about her immunosuppression being changed, prophylaxis being changed. And certainly HSV could unify all of that.
Including, I guess you don't have a picture of the skin lesions.
Correct.
But including that. Okay. So given the labial lesion, the diffuse or disseminated, at least, skin lesions, as well as some vision changes.
Right.
Okay. So she got some workup at the Outset Hospital. She got started on acyclovir and ceftriaxone, and then she got transferred to Barnes. So we've got some background, and I apologize. Actually, I don't have exactly the amount of time for the ganciclovir, but I think it's between like 3 and 6 months. And then she was treated, I believe, with acyclovir for that initial HSV lesion as well. And that's when it got that lesion resolved. So we've got some further medical history. So her ESRD was due to NSAID use in her hypertension. She does have situs inversus. And then otherwise, pretty unremarkable surgical history. You got a cancer history in the daughter, but otherwise, kind of non-risky social history. I've got a little bit more details on our transplant with induction via thymoglobulin and the HLA quantification of the mismatch. And then otherwise, for her medications, we've got some information on her immunosuppression. She's on mycophenolate 360 twice a day. She's on prednisone 5, and she's on tacrolimus 1 twice a day. For her exposure history, nobody around her has been sick. She lives in rural Missouri, but previously has been down in the South, up in Chicago, as well as in Arkansas. No other animals or farmland. She's been out of the country or out of the area once up to Puerto Rico. Otherwise, no water. She doesn't have a ton of aquariums to be exposed to, and no woods exposure. But she is a gardener, but hasn't done that for 6 months. And we're seeing her, this is in November.
Okay.
Um,
Yeah, so gardeners have a lot of exposures, soil organisms, but also a lot of fungal exposures. So sporotrichosis is the one we can classically think of. However, in my clinic, I have lots of patients who have inoculated themselves with different organisms. I don't actually believe that you can inoculate yourself with histo, blasto, crypto, or cocci. Certainly it does happen. However, I would say about 95% of patients who come to me and say, like, I stabbed myself with a stick, and then now actually positive for cryptococcus, which is actually real cases. I actually then will find a history of a pneumonia 6 months earlier or a year earlier. And then when we do this good CT scan of the chest, you'll actually often find old granulomatous disease or small infiltrates, et cetera, which suggests probably that it's a red herring, that they remember poking with the stick, but in reality, it actually started in the lungs. The other thing that can happen with gardeners around here, we've had several cases now, about 5 or 6 cases of infections from direct inoculations from vegetative matter of fungi that have never previously been shown to cause human disease. The most interesting one for me was Thyronectria austroamericana, which we had a case of a knee infection. The reason
you might have to say that one again.
Thyronectria austroamericana. And I think the reason that was really interesting is because it was a septic arthritis in a immunocompetent patient. And it's a fungus that's associated with locust trees. And those of you who like trees may know much locust trees, but you may not. They have these giant needles. They're about this big on their tree, not just on the branches, but along the actual trunk of the tree. And he had one in his backyard, and he was a gardener, and he would brush up against it all the time. And then when we published that paper, I got paged like 10 days after it came out. And it was a phone call from an ED physician in Kentucky who wanted to talk to me about Thyronectria austroamericana. And I was like, what the heck is going on? And so I talked to him, and he started talking to me about, like, I was clearing the back 40 of my family farm, and I was chopping down all these locust trees, and I have this lesion in my hand, and they biopsied it here in Kentucky, and it just grew Thyronectria austroamericana. And so he had like a Google alert for this fungus, and it popped up with our paper, and he's now a patient of mine. But he indeed has Thyronectria austroamericana, and that was the first case of it ever being shown to cause human disease, animal disease, anything. And the question is, why is that happening? And the current consensus is, because I'm not the only one who's seeing this, there's a lot of physicians across the country who do mycology who are starting to see these happen. And that's because there are many fungi that have all the things that are required to pathogenize a human being. The only thing that they don't do well is survive at 37 degrees Celsius. Fungi like it cool. Actually, there's a really cool paper in Science about 6 months ago that if you thermally image a forest floor, the coldest thing you're going to see is a mushroom. The mushrooms are actually actively cooling themselves to be cooler than the forest floor. And so as the globe is warming, we're having all of these incredible heat events. Like when it got to 42 degrees in northern France, like that's not supposed to happen, right? And we get those events, and it kills off a lot of fungus. It kills off the ones that are not thermotolerant, which creates an evolutionary incentive for fungi to become more and more thermotolerant. So we're seeing these episodes now more and more. It's still very sporadic, but the question is, will it happen? Will we actually start getting more of this?
Okay, so you're going to have different fungi species potentially causing
human disease.
Okay. Any other takeaways from this? How are you how does the current immunosuppression regimen kind of influence
Yeah, so
your thoughts?
low prednisone, a reasonable amount of MMF and tacro. So a normal person at about 11 months with a low risk kidney transplant. So I think she's immunosuppressed. So I would consider her more likely to get diseases of the immunosuppressed, but not so immunosuppressed that I would be expecting just completely off the wall stuff.
Okay. So what would be some like alternative doses that you would be expecting?
Especially if they were on high dose of prednisone. That's the one that really worries me the most because tacro is driven by levels and stuff. But if she was on a mg per kg of prednisone, or if she had a recent rejection and she was given a gram of solumedrol or something along those lines.
And do you mind talking a little bit about, I know in recent years, there's been a kind of update as to the geography of fungal distribution.
Yeah, so that was the work that was done in our group. And there's a paper that I can give you a preview right now that we're working on to be submitted because we're trying to get rid of the word endemic mycosis. We have found that the histo in the classic areas where the histo was, it's actually way outside of those areas. Coxsackie, we know from our work and other people's work, has made it all the way north up to Washington State. So really, can we just say it's down in the Sonora? Because it really isn't. There's cases of it in Utah and Idaho and Washington. And if you combine that with the fact that if we focus just on histo as an example, 80% of patients who are diagnosed with histo are initially misdiagnosed as something else. And the median number of physician diagnoses that they receive before they get to histo is 4. So that means for 80% of patients who have been diagnosed with histo, that doesn't count the ones who are permanently missed, right? The ones we miss altogether and they just die, are diagnosed with 4 different things before they're diagnosed with histo. And that's worse for physicians who think they're not in the endemic area, right? Mm. And then we go back and we look at the history of the word endemic, right? Where does it come from? It comes from the time when American medicine wasn't really medicine, right? Like in the 1880s in America, it was a trade school where we really didn't do what we do today. It was, to quote Osler, who's, probably should be a hero for all of us. If he was talking about, this was about 1890s, he said, if we sunk all of materia medica to the bottom of the ocean, it would be better for humanity and all the worse for the fishes. And so like it was people were still bleeding people at the time, right? And so the word endemic comes from this philosophy of othering a disease, where it's not present in the civilized world of Europe. It's present in those other places, right? And so endemic was referred to many viruses, to many fungi. And there's actually a movement now outside of just endemic diseases in all of medicine to literally just say like, stop. We need to stop doing that. We need to stop referring to it. It's a colonial term. It has to go away.
Thank you very much, sir. We'll give you some more information here, but not too much additional signal here that we didn't already have. So yes, on review of systems to congestion, some sinus pain and eye itching, and then the aforementioned wound. It's a wound more so than rash, as well as headaches and immunocompromise. So we talked about some additional thoughts there. What are some of the things that you might additionally be looking for on exam?
So additionally, for exam, really you want a big, thorough history of the big skin exam. That's going to be really important because I want to see what that looks like. There's a lot of talk about the different signs from meningitis. There was a study 8, 9, maybe 15 years ago now, I'm getting old, from Yale that looked at the Carnegie's and Brzezinski's sign and looked at the likelihood ratios of those predicting meningitis. And the likelihood ratio was 0.97 and 1.03, as in coin flips, right? So those are not terribly helpful. We teach them, we've always taught them, but it seems that they don't really predict meningitis. So really for me, the biggest thing that I'm looking is to do a standard physical exam to see if there's something that I'm missing. Then I would want to do a very thorough skin exam because I want to know what's happening on her skin because that's already where we have a positive. And then In terms of workup, other than the additional standard stuff, I want to see a CT, especially over chest, imaging of the head, CT or MRI, whatever we can arrange, and a lumbar puncture is kind of imperative. It has to be done right away.
Got it. So here's our exam. So vitals were across the board appropriate, afebrile. We'll gift you the ophthalmology exam. They found basically a totally unremarkable eye exam. And then otherwise, heart, lungs, and abdomen were unremarkable. And then otherwise, her neurostatus by time of arrival to here, so probably she'd gotten ceftriax and she'd gotten an LP at the other hospital, was basically back to normal. Her skin exam, as previously noted, she's got lesions in a couple places, right upper extremity, right lower extremity, and I'll give you a picture on the next slide, as well as an upper lip lesion and a left upper chest lesion. And so we'll give you the pictures here. What are your thoughts on these?
They remain the same.
Okay.
I think swabbing for HSV is reasonable on some of maybe the lip one, but that won't rule out the pathology of other things because she could have HSV on the lip and then the knee and the arm be something different. It is hard to tell. It almost looks like ecthyma, but I would expect her to be much sicker. But blood cultures would be a reasonable thing to obtain. I would, in addition to all the things that I've mentioned, I would love to talk to our dermatology colleagues and possibly get a biopsy of that skin right away. Testing for endemic mycoses, cryptococcus, syphilis. I would not, unless those come back positive, unless come back negative and we don't have a diagnosis otherwise, I would hold off on the more animal exposure, things like Q fever and Bartonella, because she doesn't have a history of it.
Okay.
Although Q fever is one of the most infectious organisms on the planet, and it has an ID50 of 1, meaning that a single organism is enough to induce clinical disease, induce infection in more than 50% of people. And so there have been cases of people who live 3 or 4 miles away from animals and farms, and then the wind just blows the Q fever in their direction. And they're sporadic cases, but it does happen. And if you ever think you're in Missouri and you're not within 4 miles of an animal, you're wrong. Because I remember driving home down Grand a few years ago, and there's just a cow walking down the street. Granted, they fell out of a truck, but still, there's a lot of animals around here.
So you have a pretty low threshold to.
I have a pretty low threshold for considering Q fever. Yeah.
Okay. All right. So we'll give you some initial labs, and then we'll head to some imaging. Broadly, fairly unremarkable. We got a white count of 12.8 with a normal diff, and I'll give you the LP. Basically, is bland with a glucose of 64. Protein was slightly elevated. It was clear. RBCs was 6 and WBC was 0. And then we will have you'd ask for a CT, so we will get our thoughts from our radiology colleagues, Dr. Adam Naylor.
Right, so here on this, I'm going to show the frontal chest X-ray first. We can see that the patient has dextrocardia with a right-sided aortic arch in keeping with their known situs inversus. We can also see there are some nodular consolidations in the right lower lung. These were new from most recent chest X-ray 1 year prior. So the main consideration would be infectious pneumonia, which can include bacterial or fungal causes. Other things to consider, given that her transplant would be PTLD, but this would be less likely, and no other abnormality is evident on the chest X-ray.
What would make PTLD? What would be some considerations for PTLD signs on imaging?
So really, it would just be, it would be chronic consolidation. So it would be non-resolution of the consolidation, following treatment for certain infections. Then that would, raise our suspicion for that diagnosis. So, I see I did the laser point there. All right, so on the chest CT, again, redemonstrates those areas of consolidation here in the right lower lung. Additionally, though, the CT reveals numerous micronodules throughout the left lung, to a lesser extent in the right lung, but most pronounced in the left lung. And the distribution is best characterized as perilymphatic. And so our main differential considerations for this would be a granulomatous process, such as granulomatous infections, or potentially sarcoidosis. So those would be our kind of the main considerations for that.
What are some of the other distributions that are really perilymphatic?
Yeah, so perilymphatic the other distributions we talk about for micronodules are centrolobular, which would most commonly be seen with airway-centered infections, and then random distribution or miliary nodules, which could be seen with disseminated, hematogenous infections such as disseminated tuberculosis or malignancy. Oh, yes. And then I can show you the MRI here, facial MRI. So these are contrast-enhanced images, and they show fluid and mucosal thickening and hyperenhancement involving the frontal sinuses here. We also see mucosal thickening of the ethmoid sinuses, and to a lesser extent, the maxillary sinuses. So these are all findings in keeping with diffuse sinusitis. Of note, we do not see any areas of mucosal non-enhancement or non-enhancement of the nasal turbinates to suggest a necrotizing or angioinvasive fungal infection. And the imaged portions of the brain here on this exam were normal.
How does that shift you?
So I'll deal with the face first. I don't think this is an invasive mucor or Aspergillus. However, that is not a disease that you ever choose to just say, I don't think it is. So to deal with this, I would actually ask our ENT colleagues to see the patient, because even if it's that range between 0.1% and 1% likelihood of it happening, I still want them seen by ENT, because the outcomes of a late diagnosis are abysmal. What's interesting about the pathophysiology of the imaging of the chest is that this is usually how primary progressive histoplasmosis behaves. So you have a larger nodule, and specifically in immunocompromised patients, right? You have a larger nodule, which is the initial site of infection, and then you have multiple micro nodules, which usually suggests that the body was not able to contain that, which in her would be reasonable given the fact that she has immunosuppression. And then you get through hematogenous spread, very much like you would see in tuberculosis. It's a very strong mimic of tuberculosis. So much so that if you go back to the old autopsy studies from TB sanatoriums, you will find that a certain percentage of patients who died in a TB sanatorium in the United States did not die of TB. They die of histoplasmosis. Up to 10% in some cohorts are patients who they look like histo, everybody diagnosed them as histo, looked like TB, everybody diagnosed them as TB. They were unable to grow tuberculosis from anywhere, but it looks so much like TB that they just said, this is TB, put them in a sanatorium, and then months or years later, they passed away. And really what it was histo all along. And while we probably wouldn't have been able to treat it at that time, we certainly would have at least allowed them to be with their family and wouldn't have separated them from their community.
Okay. All right. So we've got some further information here. So ENT was probably consulted a couple days into admission. They agreed this with exam and imaging is consistent with acute bacterial sinusitis, though of unclear etiology. Blood cultures, fungal cultures got collected. Acid fast, same as negative. We got some CMV labs, and then we've got a positive histourine antigen. It's above the limit of quantification, very high burden. Negative blasto antibody, negative cryptococcus, and the negative enterovirus panel at the outset hospital. Tachytrough trough of 2.2. There's our CSF fluid, and otherwise kind of generic infectious disease work, which is pretty unremarkable.
So this is it's a very consistent syndrome for histoplasmosis with a urine antigen above the limit of quantification. This really makes the diagnosis. But for teaching purposes, it's good to think about what are the things that cross-react with histo. What are the syndromes that could, not that I think they are, I don't think they are, this is histo, but just to know what it is. And so the full name for the histourine antigen test is the histourine galactomannan antigen, which should give you a hint as to what it could cross-react with, including aspergillus. So we've had consults in the past where we get both of these being positive, the aspergillus galactomannan and the histogalactomannan, and then we get told they have both. No, they just have histo and it's just or aspergillus and it's cross-reacting. Over 90% of serious blasto cases will cross-react with the histourine antigen, to the point where the cross-reactivity with the histourine antigen is higher than the positivity is in the blasto antigen, which means that the histourine antigen is a more sensitive test for blasto than the blasto antigen. And so I only use the histo antigen ever. I never really ordered the blasto antigen on top of that. Most fungi do create some amount of galactomannans, so you can get cross-reactivity even with Cryptococcus, although that is much rarer. And a negative cryptococcal antigen, especially with the new lateral flow assays, which have a sensitivity of over 99%, that's pretty rare. And so Cocci is also another one where you can get cross-reactivity, but really, honestly, the syndrome, the location, the behavior, everything really fits incredibly well for histoplasmosis. So a primary progressive disseminated histoplasmosis.
Got it. All right. What do you make of what's the utility of the blasto antibody in this case? Let's supposing this were a blasto case.
So
you said they're very similar.
Blasto antibody does also cross-react with histo, less so than the antigen does. And so there's some utility in trying to differentiate the two. The syndromes are often somewhat different. And so the syndromes are really more helpful for differentiating. You should also be able to get a biopsy of the skin where they're very, very different. And then so I think that's the kind of the really most useful way of saying it. But the really important thing to know about the blastomyces antibody in terms of what we see is that our lab sends it off to Mayo, and Mayo, to save tech time, will do an EIA first, because EIAs can be done in these massive panels in large groups, and the EIA IgM is just an absolutely god-awful test. And so for every true positive, we'll get about 15 false positives. And it's just the first screening test. So never take the first screening test, especially the IgM, to be a real true indication of disease. I think we get about, in our mycology clinic, we get maybe 2 a month referrals where it's like, please interpret this test. And I'm like, it's nothing. Have a nice day, sir. And so just to know that if it's just an IgM positive, it's a false positive. The EIA for Cocci also has the same thing, which is actually worse. So we don't do EIA in our process here, but if you do an EIA, if it's done somewhere else and you get a patient transferred, their false positive rate is 40%. So almost 1 in half will test positive for Cocci, which makes it a useless test.
Okay, it's very helpful. So we're going to have our pathology colleagues help us out. It's Dr. Justin Burke.
Right. So you said you wanted dermatology and ENT to check this patient out. We got it. Got by a couple of tissue samples taken from this patient. First one we received was a right thigh skin biopsy. Here we have a higher power image. Right away, this is a very busy dermis. There are a lot of extra cells here. We don't normally see that. So a lot of these from this power looked like mixed inflammatory cells. Not fairly dense, but not dense enough to make us think anything like a lymphoma or PTLD or anything like that. We're thinking more so infectious from this power, which is good because that's where we were at clinically. Over on this end, you can see we kind of have some fibrinous debris over here. Could be a touch of necrosis, but can't really. Not seeing a ton of neutrophils. Little zoom in a bit on higher power. We can see that our inflammation is mixed. So we have some lymphocytes, We have some neutrophils. We even have a couple of eosinophils hanging out in here. This is all the fibrin. And then also, subtle finding, not a lot of people would pick up on, i.e. me. These like circles here. Not really what we were, like if we're looking for fungi, typically we're looking for hyphae, and you see them just kind of as like refractile lines, just kind of in the tissue. You can see them, but we have these little circles that like you could be forgiven if you think they're bubbles. But they have these like very prominent pink borders, just something to make a note of, not used to seeing in there. Then we also, ENT got a hold of this patient. We also took a look inside of her sinuses, did an evacuation, skipped straight to high power on this one because it's largely the same. We had some non-necrotizing granulomatous mixed inflammation. This is super zoomed in. You can see our neutrophils, lymphocytes, all this background pink amorphous is our confluent histiocytes. So that's where we're getting our granulomatous from. There they are again. Just like these little circles in here with these thick pink borders, just hanging out, being annoying. All right, so when we get anything like this and we're ruling out infection, we do have some stains we can do. If we're thinking, anytime we think granulomatous, we automatically do the stains for tuberculosis. So that's acid, fast, fight. Those were negative, so I'm not going to show you those. We also have a GMS stain for fungus, and that's a silver stain that is very dirty and likes to pick up all kinds of little debris, but every once in a while, we actually find some fungus on it. So here we have some round, broad-based, looks like we got some budding there. Could I say a few more buzzwords? All right, and so those are our findings. And I have the diagnosis on the next slide. Do you think we're ready?
Yeah, definitely. It's blasto.
Yep. So we just in general, we try not to speciate on morphology because that's how you get yourself into trouble. But in this case, by the time the paranasal sinus extraction happened, there was also a tissue culture. So we were comfortable saying morphologically consistent with blasto.
Right. So we've got some additional path now. What are your thoughts? You nailed it with the cross reactivity and showing up in different ways.
Yeah, it's a very unusual to have a blasto cross-react and be that high, be above the limit of quantification. Ultimately, the treatment's the same, right? She needs amphotericin followed by itraconazole. So I think that that's certainly the case. And you made a very good point that I think is worth illustrating, which is be careful calling out fungus. There was a couple of really cool studies that were done in Emory and blinding pathologists. And pathologists got the fungus right 60% of the time. Whereas when it was specialized pathologists, so it was a specialized pathologist, she's actually married to an infectious disease doctor, and she's an expert in fungal pathology. She got it right 72% of the time. So in reality, you have to be really careful when you're calling things on pathology. And she actually wrote a wonderful review of how that covers all the things of how pathologists get it wrong. And it's not that the pathologists are wrong, it's just, it's hard. It's hard to call it. But this certainly does look a lot more like blastomyces than it looks like histoplasma, because we do see those larger structures. There are more broadly based budding. And like I've said it before, and people will hear me say this in clinic all the time. Every fungus is smarter than me. If I think it looks like histo, I feel like it's always going to be blasto. Like whenever I put my foot down, it always ends up being the other one, the one that I didn't put my foot down on. And it's just the fact that the overlap on the syndromes between our dimorphic fungi is not, the Venn diagram is not quite a circle, but it's gosh darn close to a circle. There's just so much overlap in what they can do that we really do see. It's really hard to put your foot down until you have a definitive answer.
Yeah. So we've got, oh, please.
Long time. And I don't know, there is no right answer to that. We have never done duration studies. The closest we've ever come to duration studies was the work that was done in HIV. But an HIV patient's very, very different, especially in the modern era. In the modern era, if she had HIV instead of her kidney transplant, We put her on ART and her virus is gone in 4 to 6 weeks. Her immune system is back in 3 to 6 months, and then she can control it. Her immune system is never going to be better. It's going to be better, but it's never going to be fine. So the initial recommendations were treat for life. I think now we have quite a lot of experience to demonstrate that treating for life is not necessary. I routinely will discontinue therapy on these patients, but my rule is if disseminated, I do at least a year. And if I have a positive antigen, I will follow that until it becomes negative. And then I do about 3 months of therapy after that because I realize these antigens are not perfectly sensitive. This is not well guided by data, but it is a therapy approach that is used by quite a lot of people.
So I've got a final update here. So she had an acute bacterial sinusitis, initially treated inpatient with Augmentin, then to Unison, then had her ENT colleagues go in, OR cultures with staph epi, as well as mold, and they were potentially concerned for some osteomyelitis, discharged an Augmentin, Dapto, and the antifungals that you just outlined. And then she actually came back about 2 weeks later because she had rhabdo from the daptomycin. And then the fungal culture returned blastomyces, and then you got exactly right, treatment with amphotericin and the pentoxifilline briefly while inpatient, and then loaded with intraconazole, and then discharged on intraconazole.
Yeah, I wonder how much of the sinus was actually bacterial, and especially if we needed Dapto in her at all, because we recovered the organism, and you're going to have bacteria there along the way, right? It's not a, and so I think a course of Unison or Augmentin would have been reasonable. I probably wouldn't have done the Dapto because I think it's just exposing for unnecessary risk. And there was really good data about 15, 20 years ago now that had looked at comparing side effect profiles, serious side effects profiles between IV antibiotics and heparin. They're the same, IV heparin, in terms of per diem use having a serious complication. And we would never just say, just put them on IV heparin for a while, right? So I think it's really important to be judicious of how much we use because things like that will happen.
Well, thank you very much. I learned a lot.
Thank you.